I thought this is important. There's a lack of work in concurrent disorder, and there is actually a lot to be done. But to be honest, when you start looking and trying to do the concrete work, it is not easy, and it's something which needs a little bit of struggle, and I'll talk a little bit about what we plan to do and how we plan to do it. One of the issues which I think I noticed among the clients we see is that there's a huge issue with childhood trauma and childhood traumatic stress. And one of the first things we did here, the issue with stress is a little bit a definition. Saley had the definition that stress is the body's non-specific response to a demand placed on it. This is actually both eustress and distress, while the clinicians normally only see the distress, and actually would see a definition more like this, that it's a demand that exceeds the personal and social resources of the individual. What you've already heard, I think on Tuesday, is about a study we had done with homeless, and the population we see in the clinic is very similar to the one described here. It's on average they're about 40 years old, 40% are females. There's a high number, almost 40% of Aboriginals in that group. The education is less than high school in 60% of the population, and 2/3 have been incarcerated at some point in life. And actually almost half have been in foster care. So what we did is use the childhood trauma questionnaire, which has been mentioned several times today. It's probably one of the assessments used most often. It's 28 questions, 4 scales. What I will present is the 3 forms of trauma assessed with this questionnaire. And what I want to look also is at the disorders. And we use the MINI, which is a standard diagnostic interview used to assess the DSM-4 diagnosis. First, the already mentioned high level of childhood abuse. Actually, 60% did fulfill criteria for emotional trauma, physical trauma, or sexual trauma, and if you combine it, it's about 70 to 80% of a randomized, as good as you can, randomized population of homeless people. So this is not a selection of those who have clinical issues, but just a standard, so to say, homeless people. And this is giving you a kind of overview. If you see that the level of emotional trauma on average is about 14, the cutoff for trauma is 12, so the cutoff is higher. The average is higher than the cutoff for trauma. The same is true for physical and for sexual abuse. If you look at the, so to say, average in the population, it's not astonishing that it's lower, but actually if you look at the average, and this is separated for males and females in standard psychiatric treatment, actually the clients, the homeless clients, have a higher level of abuse history than the average person in psychiatric treatment. In inpatient treatment, we are talking here. It's not outpatient treatment, inpatient treatment. Specifically with sexual abuse, there is a high discrepancy. What I wanted to look at is what does it mean for the outcome? What does it mean for the psychopathology and the suffering of these individuals? And what I have here is, so to say, the association of emotional abuse, physical abuse, and sexual abuse, and specific disorders. In this case, major depressive disorders. And we have seen already in several studies that increased risk factors or increased emotional abuse history increases the risk of developing major depressive disorder. The same is actually true with alcohol dependence. Again, all 3 factors, or the total score of CTQ, indicates that persons who've had a history of abuse have an increased risk of becoming alcohol dependent. Interestingly enough, when we looked at substance dependence, we did not find an association. In other studies, this has been clearly shown, and we explain that with the fact that actually it's almost normative to have substance dependence, like over 70% do have a substance dependence. The substance dependence rate was higher than the alcohol dependence rate. You see there's a tendency maybe with emotional abuse, but overall we did not find an association. There's a lot of studies who have looked at post-traumatic stress disorder. And you can see this is highly significant, and this is not surprising. But actually the trauma which induced this post-traumatic stress disorder is not necessarily the childhood trauma. Actually, when you look at the adult sexual abuse, if you had a childhood sexual abuse or emotional abuse or physical abuse, it all increases the risk that you will have sexual abuse again, or that you have the risk of being sexually abused as an adult. So those who have been suffering as a child of abuse are way more likely to suffer again. And the highest association is actually in sexual abuse, where you can see that the difference in the average score is the highest. The same is true for physical abuse in adulthood, and actually also for emotional abuse. That means if you have any form of abuse as a childhood, you're way more likely to be abused again or suffer abuse as an adult. So this is actually associations which have been known, I would say, by now, and which have been demonstrated several times. But to our surprise, when we looked at manic and hypomanic episodes, we again find a very high association, significant association, and that means that the risk of developing mania or actually bipolar disorder seems to be significantly increased. This was a little bit of a surprise. And the next, I looked in the literature, and actually what you find is there have been studies looking at the difference in bipolar disorder, its difference increased severity among those who have had a childhood abuse. There's more suicide attempts. There's actually also earlier onset. There is more rapid cycling. But there's also, our data also suggests that there might be a causal link, or at least they might increase the risk or be a marker for increased risk of bipolar disorder. We also looked at schizophrenic psychosis, and we did find an association. And again, we were quite surprised because there's little reports in the literature on abuse increasing the risk of schizophrenia.